Hi, I'm David King-Lassman. This is Explore XR. And today, unusually, I'm joined by two guests, and I'm delighted to be in the company of Arun Gupta and Johnny Martin from Cambridge University Hospital. Gentlemen, thank you so much for joining me today. Arun, let me start with you. Please introduce yourself. Tell the audience a little bit about you and what you do at Cambridge University Hospital.
Thank you, David. Thank you for the invitation to join you today. It's really exciting, and I hope we have a good discussion. So my name is Arun Gupta. I'm an attending or consultant in anaesthesiology and neuroscience and trauma intensive care at Cambridge University Hospitals. I also have a joint appointment with the university hospitals as Director of Medical Education, and also the Health Partnership of Cambridge University Health Partnership as Director of Postgraduate Education there as well. And that Health Partnership is a combination of three hospitals: the Addenbrooke's Hospital, the Papworth Hospital, which is a cardiothoracic unit, and the Mental Health Trust, which is largely all mental health, both community and inpatient, and the University of Cambridge. So those four partners form the Cambridge University Health Partners, which I'm part of.
And Johnny.
Hi, David. So my name is Johnny Martin. I'm an anesthesiologist and intensivist working in the general transplant intensive care at Addenbrooke's Hospital. And I'm also the co-lead for simulation for the Trust. So involved with all forms of high fidelity, virtual reality, and now mixed reality simulation.
Fantastic. Thank you, gentlemen. So I know that you guys are employed by Cambridge University Hospital, and there is a distinction between the hospitals and the university. But of course, the Cambridge brand is an incredibly prestigious one and a very well-known one over here in North America. Of course, the university is counted among one of the best in the world. Can you talk a little bit about the distinction between the university and the hospital group? So you're not employed by the university, but there is a connection, right?
So personally speaking, I have a joint appointment as an affiliated associate lecturer with the university. Many of the attendings or consultants at Cambridge University Hospitals also have contracts with the university, but a proportion are solely employed by the university, and they are largely pure academics who do some clinical work. But there's a big cross activities between the university, which has many institutions within the biomedical campus at Cambridge, which is evolving, and the hospital. So the distinction is there, but actually the richness of the collaborations between the university and both the clinical school and the hospital are very real and pay massive dividends, both for biomedical research and for clinical practice.
Right, and so the research that's done at the university then spills into the hospital, and the hospitals are, among some of the most cutting edge in the world, developing new and innovative techniques, well known for some landmark firsts, right, at Addenbrooke's and other hospitals in the group.
Well, yes. So the first heart transplant in the UK was done at Papworth. The first liver transplant was done in Cambridge University Hospitals many years ago. But from that has evolved huge areas of research and development, and the hospitals alongside the university still rank amongst the leading outputs of clinical research and basic science research in the world.
Right, and so it's pretty reasonable to say that the healthcare sector in general has always been at the cutting edge of innovative technology, because it kind of needs to be, as it constantly strives to provide the best care and treatments available. Johnny, to what extent do you see technology driving your thinking? And can you talk about, in your tenure there, how you've seen technology sort of shift the landscape?
So I think Aaron and I both work in a very high-tech environment in critical care. It would be wrong for me to paint myself as anything other than a massive technophile. I know that healthcare education and delivering quality healthcare is more than just technology, but that technology can act as an incredible force for good in delivering good healthcare, both by the bedside and to the future generation of doctors coming through. I think some of the technologies that are coming through now enable a degree of standardization in the delivery of healthcare training that we've never seen before. I think one of the ways that people refer to their training historically would be, my mentor was Professor X, and Professor X showed me how to do these many wonderful things that I can now do, and I show the next generation of doctors how to do. And I think whilst that's good for those that live under the aegis of Professor X, it's not so good for those of us that don't have the good fortune of having top flight staff on hand. And I think one of the things that technology can do is bring a degree of standardization to the delivery of medical education that, whilst it's possible within the confines of classroom-based learning and is easily done in that environment, is exceptionally difficult in a very apprenticeship-based and hands-on specialty such as medicine. And I think one of the things that technology, I hope, will enable us to do is to bring leading minds into areas where they would not normally inhabit, and enable the standardization of healthcare training in a way that we haven't seen so far.
So that's super interesting. Can you give an example of how you might see that being applied in that kind of context?
So I think if you take it from the very simplest, you could have someone performing cardiopulmonary resuscitation, CPR, say in a environment like a swimming pool, and you could have a professor of resuscitation medicine in a teaching hospital observe candidates across a wide range delivering CPR and singling out good practice, bad practice, in an environment that they would never normally get to. So with the very simple things, but also looking at across country divides, you could have a professor of surgery beaming a technique that he performs across the world to those in less fortunate circumstances to see and educate how he performs various techniques. I think the scope for this, how one could imagine bringing minds together for the benefit of patients, is almost limitless. That has to be tempered by the reality of what's possible. And I think as the technology improves, so the ability to enable us to dream big about what's possible in healthcare training increases. And I think there are step changes perhaps ahead that will enable us to do that. I think from moving from pretty average video conferencing now through the age of Zoom, through which we're all living, and going to the next step of being able to actually be in a shared experience together, I think is very exciting.
Right, getting into the metaverse realms, of course, when we talk about that. So, of course, people will know now that GigXR is working closely with you guys to develop product. We're thrilled to be partnering with you guys, and clearly honored. It's a great privilege to be working with you and the team. What first appealed to you guys about mixed reality, particularly as opposed to some to technology like virtual reality? What appealed to it, and what drove you towards looking at investigating this technology to apply it in healthcare training?
I think virtual reality is great. So like I say, I'm a technologist, and I think what we know of virtual reality and what we've seen of its delivery for a healthcare environment is interesting and it's exciting, but it has significant limitations. It is by definition sandboxed. You are in an environment that is wholly created for that environment. And that has some particular limitations currently that limit its applicability. First of all, there are people who just don't get on with the technology. There are challenges to those that feel nauseated when they put it on, or just don't get on with the technology itself. But inability to be integrated into an environment which is already in existence is a real challenge. So say, for instance, you have a piece of software that recreates an emergency department resuscitation room in virtual reality. That's great. But if you're in a resource-poor environment and your environment looks very different to what's on offer in the virtual reality environment, you're very limited in what you can change for that piece of software. I think the benefit of mixed reality is you can choose as much or as little to superimpose on an already existent environment to facilitate the training that you're trying to do. So you have the option to recreate a mannequin, as it were, and place that mannequin in space within an already existent room with which people are designed to get familiar. And I think it also enables people to have much more in the way of situational awareness, one of the key tenets of what we try to teach people who are managing serious crises that can evolve in healthcare.
So, of course, this is nascent technology, and we're very much in the early stages of it. What do you imagine are going to be some of the challenges that will be overcome? What kind of milestones and measures do you expect to see and reach over the course of the next year or two?
Well, I think if we look at what GigXR has delivered already in terms of their HoloPatient and HoloAnatomy, these are fantastic exposés of what's possible with the graphical interface and the phenomenal visuals that are on offer need to be combined with the ability to interact with those visuals. And so the ability to do more of what is required of a clinician or a healthcare practitioner in terms of actual physical interaction with a mixed reality environment will enable the training to take on that next level. I think the more you can do rather than the more you can see, then the environment that you're training in will become richer and richer over time. And I can only see that as a one-way street. I can only see things getting better and better from that perspective. And I think the other major challenge is we talk about simulation-itis in the sim center. So when we're confronted with a jarring perception of what is being delivered by the simulator and what reality would feel like. So say, for instance, you have a mannequin whose pupils do not react when you shine a light into their eye. We have to tell the candidate the pupils are reactive, but the candidate can clearly see that the pupils are not reactive. And so that jarring nature of what is possible within the environment leads to the sort of breaking that contract or suspension of disbelief that's inherent in any simulation, for of course they are all simulations. And I think as the technology improves, and so the need to be au fait with the platform before you interact with it reduces, so the ability for anyone to put on a headset and dive into a clinical environment will increase. Yeah.
And Arun, perhaps you can talk about some of the real world benefits you imagine are going to come from this type of technology.
So I think, just following from what Johnny was saying, the outputs of this really is that we want to ensure that we get as realistic an experience as possible. And, in future, that may or may not be with headsets. It may be with other bits of equipment or none at all. It may just be, purely handheld devices. But the key thing from my perspective is that I think we want to make sure we widen access of simulation and training to areas that otherwise would not be able to. So what we want to start to move away from is the big teaching centres being the only place where you can learn how to do complex or even simple procedures or whatever the learning requirement is. And so that can be accessible from a distant place, distant hospital, even distant office. And as technology improves, I think we should be able to get both the improvement in the immersive aspects of the simulation or the software or the equipment that we use, and also enhance the access to that, so that it's available for as many people as possible.
Right. And a lot of people that I've spoken to already talk about extended reality driving things like learning outcomes, the speed at which a training doctor or nurse can learn certain aspects of their curriculum. Knowledge retention, of course, has been seen to go up. And ultimately, what we hope is that that's going to drive patient outcomes, so reducing risk. Which of those do you think is the benefit that is most likely to be seen in the early days of what we're doing together?
So I think quantifying patient improvement in patient outcome for techniques like this is quite difficult. And largely there are so many, because there are so many variables of what becomes a patient outcome. But there are surrogate markers that we could perhaps use. And those are, I think, we're beginning to evolve. I think the work we're doing together will help identify those more carefully and more reproducibly, so that not only we can do that and develop things to demonstrate that, but it can be used as a benchmark for others to do the same with other bits of equipment. So ultimately, we all want our training to demonstrate that patient outcomes are directly affected. I think that's going to be very difficult, but we can look at indirect measures, right, which we will develop.
And of course, you're making a fairly significant investment in this technology, not just in the work you're doing with us, but you've also taken on a PhD student doing some research into extended reality. Can you talk a little bit about that? What are you hoping to see? It's hard to predict, obviously what the thesis of that PhD candidate will be at the end of the research period. But what are you hoping is going to come from that?
So again, there are a number of outputs. I think, first of all, it's an innovative collaboration between university or academia, NHS trusts and industry. So that sort of triangle of collaboration is not new, but it's new for the educational field. Secondly, as we mentioned, looking at surrogate outputs or outcomes for interventions with mixed reality and virtual reality techniques. And thirdly, how we properly evaluate either bits of equipment or software or material of any kind when we and how we benchmark that against other learning outcomes. So I think this PhD will actually prove to hopefully develop some templates or bases of how we can compare and evaluate products.
Fantastic. Johnny, of course, one of the unique features of healthcare as a profession is that you have this enormous learning curve, many, many years in med school, but you never stop learning as a practitioner, as a doctor. How extensive do you think mixed reality will be as a medium for not just teaching trainee doctors and nurses, but also retraining in hospital environments, in clinical settings, and so on?
I think it has a role. One of the things that it's nice to recreate in the simulation environment is the serious and the rare, and the ability to assess and inform using simulation is very high. I think obviously healthcare is running red hot at the minute, and it's difficult to see far into the future of how things in terms of assessing more senior doctors is going to look. But the ability for any scenario to be recreated with the donning of a headset to place someone in an environment that either may be familiar to them or may be completely alien to them, to test them in ways or to test their expertise in ways that are not easily done in the classroom, I think is one of the main draws of this technology. The ability to recreate any environment that you should choose, I think gives the ability to assess more senior doctors as well as those that are still in training.
So you're beginning to sort of answer that implicitly, but if we were to look out into the future, 2, 5, 10 years from now, where do you see mixed reality going? how extensive will its usage be, do you think, in institutions such as yours? And how is it really going to drive the way we do things? And be as imaginative and as creative as you like.
I think if you have the ability to interact with the environment in a fluid and natural way, that the possibilities are endless. I think the opportunity to standardize care in a way that I've described, from being very, institutional related to basically nationwide or worldwide, having a standardized way in which something is assessed and taught, is incredibly interesting. I think the sort of distant horizon for mixed reality is for that ability to teach, assess, and develop learning across both specialties within medicine and many, many countries. Basically gives you a limitless opportunity for the technology. It will be limited by the technology itself, and one of the things, even if we've seen the evolution of the HoloLens thus far, it's an incredibly impressive technology. Who knows what Mr. Zuckerberg's got up his sleeve as the next gen for VR and AR from his perspective. But I'm sure things will continue apace in the years to come, and I'm really excited to see what comes of that ability to naturally interact. I think a lot of things in healthcare require very deft movements, and so when the technology comes of age where it can actually detect those deft movements, then things will really improve. You're then starting to think about dry running surgical procedures in the mixed reality space, and really from there, there are endless possibilities for improving patient healthcare, improving training, and improving patient outcomes.
Arun?
Just just on that note, a couple of things really. Johnny talks about technology and improving all the time, and that's absolutely the case. But what we see, not just in the educational field, but also in the clinical setting, is that you can have a really good piece of technology, but it just may not be applicable in the healthcare setting. And I think that's where the evaluation of these things is so important. And as you mentioned, looking forward, we may look at how we develop the VR, the mixed reality, or the virtual environment to replace things like cadaveric training, so that you don't have to practice on human bodies. You can practice in the virtual environment. And indeed, that's sort of a centre we're trying to set up in Cambridge, in collaboration with the Department of Engineering, Institute for Manufacturing, and others. And which is why, being around the Cambridge campus is so stimulating and vibrant.
Well, I'm incredibly excited about the work that we're doing together. For us as technologists, being able to work with subject matter experts as distinguished as yourselves is thrilling for us. And I'm incredibly excited about the product that we're building and the impact that it's going to have right across the board. Any final comments from either of you before we end the show?
I think from our point of view, I speak for Johnny and the whole team really. I think it's one of our first forays with working in the educational space with industry, and we've been thrilled to work with GeekXR and yourselves, and we hope that it provides dividends for something to produce that's useful and widely accessible.
Well, that's fantastic, and thank you both for your vision and innovation, and for joining me today on Explore XR. Have a great day. I'm David King-Lastman. Thank you all. Have a good day.